Welcome to the Introducing Single Session Walk-in Therapy, an emergent form of service delivery webinar presented by the American Psychological Association. Thank you for joining us. APA is delighted to bring you this webinar, which is an introduction to the major assumptions and practices of the single session walk-in service delivery model. Let's begin with a few housekeeping notes. At this time, all lines are muted. If you require technical support, please submit questions within the Tech Support tab on the right side of your screen, not to be confused with the Q&A tab. You should be able to see the slides live. If you experience technical issues, please try 1, refreshing your browser window, or 2, trying a different browser. If you are behind a corporate security wall that has not approved this website for access, please contact your technical support team. To view the slides in full screen mode, click the screen icon next to the live lower right-hand side of the slide and press exit to exit the full screen. To access the PDF file of today's slides, please download them from the link provided on your screen or from the resources link in your Beacon Live course dashboard. We encourage you to submit questions about today's topic through the Q&A tab on the right side of your screen throughout the presentation. Questions will be answered during the last 15 minutes of this webinar. Due to time constraints, we may not be able to answer all questions. If you would like to rewatch this session, a recording will be available within 5 to 7 business days of the original air date. You will be able to access this from your course dashboard. CE credits. To obtain the 1.5 APA continuing education credits offered in this webinar, you must click OK when you see the attendance verification box appear on your screen during this webinar. All you need to do is click OK. Remember to respond to all attendance verifications you see. You must also complete a webinar evaluation, so stay online through the conclusion of the webinar and you will see a pop-up appear on your screen with access to the evaluation. A CE certificate will be emailed to you and will also be available for download in your course dashboard. If you have any questions about continuing education credits, please email cpe@apa.org. Now it's my pleasure to introduce today's presenter. Dr. Bobel is a licensed psychologist and an ABPP family psychologist. His career has been dedicated to brief, strength-based approaches to psychotherapy. He and Arnold Slive co-edited When 1 Hour is All You Have. He is co-credited Single Session Therapy by Walk-in or Appointment, and with Michael Hoyt recently published Creative Therapy in Challenging Situations. He has taught graduate courses and workshops in single session therapy in the United States, Canada, Mexico, and Australia for over 30 years. Dr. Bobel, when you're ready, you can take over.
Thank you, Susan, for the introduction. Good afternoon, everyone. I missed the sign that we were on. So welcome to Introducing Single Session Walk-in Therapy as an emergent form of service delivery. I'm honored that APA invited me to share a snapshot of the work my colleagues and I have been doing for several years now with you. Before we begin the presentation itself, I'd like to just provide you with a brief introduction of myself to help establish some context for single session therapy. I'm an emeritus professor of psychology and a founding member of the faculty of the doctoral program in counseling psychology at Our Lady of the Lake University in San Antonio. I've been practicing single session therapy for nearly 30 years now. My primary clinical setting is a university-sponsored mental health center located in an underserved area of San Antonio, Texas. And the primary ethnic group represented in that neighborhood are Latino and Latinas. I've taught graduate courses and workshops in single session therapy in the US and Canada, Australia, Mexico, and soon in Finland. I see that there are already questions populating the chat box. During the presentation, I'd prefer to table these questions till the end. And I've reserved some time this afternoon for us to be able to get to some of your questions. If you have technical difficulties, the support staff are monitoring the chat window, and they will be able to assist you with technical kinds of things. I'm not sure I'm seeing the slides advance. Here are the learning objectives for today's session. I won't read them to you. You probably have a copy of the PDF. There are 3 on this slide. There were 2 that were sent out to you and a third one that I added a little bit later. I hope this webinar does stimulate some interest in further training and discovery of how single session therapy can be helpful in your practices. This is the ambitious agenda I have for us today. Could somebody confirm for me? I'm not seeing on the slides that they're advancing. Is the agenda slide up, Susan?
Hi, yes, the agenda slide is up. Would you like me to advance the slides for you?
All right, I will assume that it is. This is an extremely ambitious agenda we have, and in keeping with the single session idea that it's not just an hour, it's a whole hour. We have a whole hour and a half here today to cover most of this agenda. I plan to be done with the structured part of the webinar about 15 minutes after the hour so we can have time to answer questions. And I think you've all received copies of my slides, so I won't read these to you. This will be a very general workshop or presentation on the concepts and practices guiding single session therapy. So I want to start with inviting you to consider why single session therapy might be useful to you in your practices. Still not sure the slides are advancing. The first idea is that a large body of practice-based, empirically based evidence supports this service delivery model. And I'd refer you to the appendix, the research appendix that's in Hoyt and Tallman's 2016 book, Capturing the Moment. And by the way, it's in the bibliography in the handouts. In an interview recently, Michael Hoyt said, the people who tend to do best with single session therapy can identify a relatively specific goal, dealing with grief. For example, dealing with grief, building self-esteem, validating feelings. In some studies, single session therapy has been shown to be helpful to reduce anxiety, recurring nightmares, alcohol abuse, and self-harm. And it's also been shown to be helpful in working with phobias and panic attacks. Now, the second thing to consider is that brief therapy is, most therapy is de facto brief therapy. Most clients do not attend more than 5 or 6 sessions tops. So this approach can help you capitalize on the opportunity to be helpful to your clients who may not return anyway. The next consideration is that agencies that are dealing with long waiting lists have found that moving to this model can significantly reduce or eliminate waiting lists. The fourth idea to consider is that most conventional long-term approaches to psychotherapy are expensive, pragmatically impossible for huge segments of the population, and unnecessary for 80% or more of the common presenting problems in most practices. And finally, doing single session therapy can boost your morale. Bloom reported over 20 years ago, and I quote, "There's no question but that mental health professionals tend to view early and unilateral termination by clients as a sign of therapeutic failure and client dissatisfaction." So it may be reassuring to you to know that empirical studies of client satisfaction and the length of treatment, particularly with regard to single session therapy, consistently fails to support that the point of view that early termination is the sign of therapeutic failure or client dissatisfaction. In other words, studies with clients and therapists have shown that using single session therapy has been good for clients and good for therapists. Now, let me see, I want to advance the slide here, but it doesn't seem to be work. Oh, there we go. I'd like for you to imagine something for me for just a minute. Imagine you're about to see a new client for the first of an ongoing series of sessions. And imagine a typical client, not your easiest, not your hardest, but imagine how you would normally approach that first session. How would you begin it? How might you explain the process of therapy to them? What would you expect to achieve in the session? And how might you end that session? So let me just pause here for just a few seconds and let you consider that, maybe make a note or two about how you prepare yourself to see somebody for the first session. Now, let's continue this thought experiment for just a little bit. The day before the session, the client calls you, the same client calls and says that they're intending to move away to another city. In fact, they're moving the day after the appointment they have with you. And they're not going to be able to see you for more than this one session, but it's very important to them that they see you. And they reassure you that they're very interested in getting your help, but tomorrow's session will be the last that you'll have with them. Now I'd like to invite you to imagine how will you begin this session differently than you might ordinarily begin a session. How might you now explain what the process of therapy is? What would you expect to accomplish in that session? How might you end it? If you're like a lot of therapists that I've talked to and presented this question to, you might share some of the experiences my clients have had. So let me show you those. So next slide, please. I understand somebody's going to advance them for me. That's terrific. If we were live, I wish we could have a discussion about this. But over the years during live presentations like this one, I found the following are some of the most frequent responses. Perhaps the most frequent ideas are dispensing with gathering extensive background, history, and demographic data. For most cases, not all, but most cases, this data is not needed in a single session scenario. Furthermore, you might know that this will be your first and last session with a client, so the data that might be needed for longer-term treatment planning is actually pretty unhelpful. Now, of course, basic demographic data and consent documentation are always done in single session work. And let me just say this in case I forget to bring this up later. Most of what I'm talking about today will apply to about 80% of the clients that hit the front door of a private practice or a mental health clinic. So there's a smaller percentage that are outside that window, but this is generally speaking throughout this workshop, not the edge cases. And secondly, the latter two items that are up there on the slide are key to successful single session therapy. We work really hard at the first session and early in the session to find out what clients want from the session, and then work hard with them to be sure that they get what they wanted from the session. Single session therapists don't treat diagnoses. They treat the problems that people who have diagnoses present with. And there may be a question about that we'll get to later. But I'd like to turn now to the three common research findings that are the foundation for single session research. So if we could have the next slide. So we're all psychologists and we all want to base our practice on research evidence. And these three findings are common in investigations about psychotherapy. The first interesting finding is that the most common number of service contracts that clients attend is one. One's the modal number of visits across agencies, across mental health professionals, across theoretical orientations. And then that's followed by 2 visits, 3 visits, and so on. In fact, in many, many studies, it's been demonstrated that anywhere from 40 to 50% of clients that come for therapy only come one time. And the literature on that phenomenon frequently refers to it as client dropout, premature termination, psychotherapy attrition, and so forth. But many studies have found that when we ask clients who didn't come back, why not, they say it was because the session had been helpful and they didn't feel a need to return. The second major finding I'd like for you to consider is, as I just said, of the people who attended only one session, 50 to 75% of them say the session was adequate given their current circumstances. And one of the intriguing things about this research for me is that many of the clients in those research studies weren't attending a planned session of single session therapy. Often we find that clients benefit from the intake visit or an assessment visit and other first-time encounters with a psychotherapist. So one of the things this tells me is that clients are the best judges of how many psychotherapy sessions will be helpful to them. And if we work deliberately in that first session to make it useful, the clients will be benefited even more. Now, the third finding is, ironically, it's almost impossible who will come only one time and who will come for more than one session. It's impossible for clients to predict how many sessions of psychotherapy that will be helpful to them, and it's impossible for psychotherapists to predict ahead of time how many sessions the clients will attend. Now, this is different from how many that we think they should attend, or how many our treatment plan or protocol specifies they need to attend. I'm talking about how many they will actually attend. In fact, several studies have shown that therapists tend to overestimate the number of sessions the clients will need to reach a successful resolution. In fact, one study found that psychotherapists overestimate by a factor of 3 the number of sessions that a client will need when compared to the number of sessions the client says that they think they will need. So simply said, if the client thinks that they will need 2 or 3 visits with a psychotherapist, the therapist will be estimating 6 to 9 visits for the same client. There's an extensive bibliography that came with your handouts that summarizes, that has the studies that these 3 research findings summarize. So let's go to the next slide and define what single session therapy is. Single session therapy is therapy that the therapist expects from the beginning to potentially comprise a single visit. The therapist acts as if the first visit will be the last. Now, this is the definition that we used in our recent book, Single Session Therapy by Walk-In or Appointment, and it's in the bibliography. One of the co-authors, editors of that book, Moshe Talman, published the original book on single session therapy 30 some odd years ago, and he operationally defined single session therapy like this. Single session therapy is defined here as one face-to-face meeting between a therapist and a patient with no previous or subsequent sessions within a year. As such, single session therapy is the most frequently used length of therapy. Now, it's important to note, at least it's important for me to note, that Tallman was defining single session therapy in that way because he was talking about the original single session therapy research project where they followed up clients to determine whether or not they had returned for therapy within a year. But over the years, the definition of single session therapy has been refined and broadened somewhat, and I'll give you some other examples of understanding what single session therapy is shortly. But first, I want to address some of the myths or misunderstandings about single session therapy. So maybe we could have the next slide. So we've defined single session therapy, or I've at least given you one definition of single session therapy, and I want to dispel some of the myths that you may have and other people may have about what we're talking about when we're talking about single session therapy. First of all, single session therapy is not a theory of therapy in the same way that cognitive behavior therapy is a theory of therapy, or solution-focused therapy, or narrative therapy, or psychoanalytic therapy. It's not a school of therapy. I prefer to think of single session therapy as a service delivery model rather than a theory of therapy. As my Australian colleague Jeff Young wrote, a fundamental definition of single session therapy could be anything that derives attitudinally, clinically, and organizationally from accepting the 3 research findings I presented a couple of slides back. And as a matter of fact, Jeff has started referring to SST not as single session therapy, but as single session thinking. An important point to make here is that single session therapy is also somewhat theoretically agnostic. Many types of therapy can be adapted to a single session delivery model. Generally speaking, strength-based models work best. Models that prescribe multiple visits are obviously not suited for single session therapy. There have been a number of papers published describing single session therapy using solution-focused therapy, narrative therapy, cognitive behavior therapy, emotionally focused therapy, and many others. And I've tried to include as many of those as I could in the bibliography that you've been provided. The second myth is that single session therapy isn't real therapy. This goes along with the third myth that long-term therapy is the gold standard for psychotherapy. Well, the practice of single session therapy is indeed a real therapy to the extent that it uses some theory of therapy that I've mentioned a little bit earlier. There are some psychologists who have the understanding that psychotherapy is multi-session therapy and that's the gold standard. It's not necessarily the case. I was having a conversation with some university counseling center staff a while back, and they were explaining to me how they scheduled appointments for clients coming into the counseling center. And what they told me was they offered single session therapy to students as well as multi-session services. And I asked, well, what's the difference? And they said, well, we think some students will benefit from single session therapy and others need real therapy. And that's the myth that I'm trying to dispel here. Jeff Young said that although we psychologists, we psychotherapists may think all of our clients need the Rolls-Royce treatment, but they're often happy with the Nissan Spark. A third common belief in our field is that more is based more on theory than on research, and that is that some clients have such severe complicated problems that one session of psychotherapy won't be helpful. Now there's a lot to parse here. The definition of helpful, obviously, and the definitions of severe and complicated. But very simply, people who have complicated, severe, and long-standing problems frequently benefit from a single session of therapy. 25 years of research has challenged the belief that single session therapy won't help in these circumstances. Perhaps the best way to get a grasp on how single session therapists work to understand how single session therapists work is to understand that we don't let a diagnosis get in the way of our providing help for the specific problems clients come to us with. The fourth myth is that, or the fifth probably up there, a myth that single session therapy is designed for low-income minority clients who can't afford to attend what we referred to earlier as real therapy. Now, economically, it is easier to offer single session therapy in settings whose business model is not one of private practice. We have also found that single session therapy and its walk-in variety make more sense to potential clients who are less privileged than the ideal client we learned about in graduate school. However, many therapists who recognize the utility of single session therapists treat each session as if it would be the last with every client. And the last myth is that this is merely a Band-Aid. This isn't a comprehensive approach. Well, the fact that single session therapy is thought of as a Band-Aid, that calling it that's intended to be disparaging, but it's actually a compliment. We have found over the years that bandages have been used for centuries, and primarily because they reduce infection and prevent the spread of disease. And metaphorically, that's what single session therapists think that we're doing, is that we're reducing infection, which is that a small problem escalates and becomes bigger and bigger and bigger if not treated, and spreading the infection. So we know that the infection can spread to other parts of somebody's body. We know that socially people interact with their neighbors and close family members, and their problems can interfere with their relationships with other people. So what we tried, one way of thinking about the utility of single session therapy is we prevent problems from festering and getting worse. And we try to contain the problem so that the harm to the client's social and family contexts are mitigated. Okay, let's go on to the next slide and talk just a little bit more about what single session therapy is. So let's look at some other ways of thinking about what SST is. Sometimes I refer to it, you'll hear some of us talk about it as one-at-a-time therapy. We were trying to get, by stopping calling it single session therapy, we were trying to get away from the idea that someone would come in for a session and that's the last opportunity they would have for therapy or the last opportunity that we would see them. We adopted the one-at-a-time idea to dispel the idea that single session therapy was like a one and done approach. Someone said, oh, okay, it's not a treat 'em and street 'em idea. Single session therapy requires a trained licensed mental health professional to conduct single session therapy appropriately. It's not a form of peer support or paraprofessional activity. It's a service delivery model that encourages therapists to consider adapting their current practice to the one-at-a-time idea that each session could be the last that you have with a client. It's a strengths-based approach that capitalizes on our client's strengths and resources. It's an approach that does not rely on diagnostic thinking. It's an approach that assumes that the small changes that can be accomplished in a single session will lead to larger changes down the road. And lastly, single session therapy is never, ever the last opportunity for the client to meet with a therapist. In our way of thinking, however, the decision about the next session is always in the client's hands, not the therapist's. I'm going to pause just a second and see. I was looking through some of the questions here to be sure I was keeping up with those. All right, so let's move on to the next slide. Some people may be wondering what the job description of a single session therapist would look like. So here's some characteristics of the qualifications for single session therapy. Earlier I said that being a trained mental health professional with skill in an evidence-based psychotherapy is necessary. The single session therapist needs to have the skill to build a therapeutic alliance relatively quickly. Now, I won't go extensively into this, but some of you may have noticed that I use the word alliance and not relationship. I prefer to think of what we establish with a client as a working alliance. We're in this together to do something. A relationship connotes for me something much different, and so I prefer to think of it the alliance rather than a relationship. The successful single session therapist will believe that something meaningfully productive can come out of each meeting with the client. In fact, one of my colleagues says the only theories of psychotherapy that can't be applied to a single session service delivery model are theories of psychotherapy that think that nothing good can happen in a single session or in one session. Now, I've found that psychotherapy works much more effectively and efficiently if we learn our clients' language and metaphors and communicate with them in non-clinical, everyday language, that we reserve talking using diagnostic terminology and academic terms about problems and solutions. We can use that language with our clients. With clients, we want to use everyday language and metaphors that make sense for them. Single session therapists have faith that our clients are the experts on their lives and their problems and what will work for them. And we'll see this turn up again shortly when we talk about the single session mindset. And lastly, a professional must have the willingness to put in practice reading and supervision to master these new ideas. This introductory webinar could be just the beginning of that process for many of you. Let's move on to the next slide. So we adopted the motto in our clinic a number of years ago that every case has the potential to be a single session case. So we don't conduct any session as if there will be another session. In other words, we do one session at a time. We prefer to think of a single session of therapy as a solitary pearl. As you know, a pearl begins as a solution to an oyster's problem. The formation of a pearl has a beginning, a middle, and a point where it's complete. If a jeweler later anticipates making a long string of pearls, then each one pearl is understood as related to or connected to the one that's next to it on one side in the string and the one that comes after it on the other side. But no pearl truly stands on its own. If we think of each session as a pearl in ongoing therapy, each session is always contextualized by what came before and what's coming after. But each pearl, each session is a complete standalone session. So a string of sessions is like a string of pearls. Just recently, another person was saying, well, you know, that's kind of like a book of short stories. Each story, each chapter in the book is a complete story that stands on its own and could have come before or after any of the other chapters, but all of those chapters together form a book. That's getting at this idea of a one at a time self-contained model. So we encourage therapists to consider each session as the creation of a solitary pearl that has a beginning, a middle, and an end. And I'll show you that structure a little bit in just a few minutes. And of course, any single session could have had sessions that came before it or after it. But the current session is going to be complete and stand on its own. Now, clients have informal therapeutic encounters such as talks with their clergy, getting advice from friends, and even, excuse me, occasional self-help books. Those are also factors that could connect one session to the next. So a single therapeutic encounter we never view as an isolated event in a client's life. Okay, let's go to the next slide. We're going to turn now to the single session mindset. These are a collection of assumptions and taken for granted notions that are important for single session therapists. And we could probably spend the whole day just talking about the single session mindset. But I will go through these briefly and quickly with you and recommend several of the sources in the bibliography for more elaboration. So let's go to the next slide. So the first item in my list of the single session mindset is that we think clients know what works best for them. This means that we spend time learning from our client what's worked for them in the past, what their theory of change is, how they understand the purpose of the session. We don't make a priori assumptions about what they're lacking, what they need to have replaced. We look for what they have and know about their problems that can help them resolve their problems. We see the clients as experts on themselves. We think that there's nothing wrong with somebody that what's right with them can't fix for the most part. The next idea is that clients are much less interested in psychotherapy than we are. We have made careers out of psychotherapy. We read books about it. We talk to other people about it. We even spend several hours on a Friday afternoon attending a web seminar or webinar on psychotherapy. With very few exceptions, most clients are far less interested in investing a lot of time and energy in psychotherapy. For example, I wonder how many of your clients right now do you suppose have ever attended a 2-hour workshop on how to be a better client? So what's important for us is not necessarily what's important for clients. Next, the data that describes the trajectory of change in psychotherapy is clear. Most of the improvement in psychotherapy takes place within the first 5 or 6 sessions. And in fact, in most studies, there's a huge increase or a huge change in functioning that occurs between a first and a second session, which leads me to conclude that the first session is very powerful. Many of you have experienced that phenomenon, especially with long-term cases where after a year or two you see from week to week there's just very gradual change or improvement, if any. The biggest change happens early on. Next, rapid change is common in human experience. Malcolm Gladwell called these tipping points, those small but sudden changes that have significant ramifications in people's lives. Almost all of us, when we were young psychology students, sat in an introductory psych class, and we were exposed to Boring's ambiguous figure. You know the one I'm talking about. If you look at it one way, it looks like an old woman. If you look at it another way, it looks like a young woman. And the illusion was quite strong for us the first time we encountered that figure. But soon we were able to see both the old woman and the new woman in the drawing. That we had to make a shift in our understanding of the world, a shift in perception that enabled that to happen. And that change or shift in perception happened suddenly, and it's endured. In fact, almost all of us, if we were presented with that image or a similar one now, would immediately see both images. And we learned we learned years ago how to perceive differently, and it stuck with us. And we haven't had to reinforce that ability with weekly training or periodic boosters. What you experienced was a relatively permanent and lasting change in your perception that even generalizes to other areas of your life. So you may think that's a trivial example, and perhaps it is. If you're interested in more substantive examples of deep, sudden changes in human experience, there's a book by William Miller, who's better known now for motivational interviewing, but a number of years ago wrote a book called Quantum Change, and it's in the bibliography, and describes these deep and profound changes that many people have experienced in their lives. And by the way, none of them occurred with the benefit of a psychotherapist, so I heartily recommend Miller's work to you. The next item in the mindset is that it's well known that we communicate overtly and covertly to our clients about how much change and how quickly to expect change to occur. As an example of overt communication, we were all taught to introduce the process of therapy to our clients. We learned to say something along the lines of, well, Mr. Client, it has taken you a long time to develop these bad habits, these distorted ways of thinking, or whatever other symptoms they're presenting with. We then say, it's going to take correspondingly a long time to undo these problems. That sets up the client to have a rather pessimistic view of how therapy will be helpful to them. Or somewhat more subtly, we might end that first session with, so are you free on Tuesday afternoons at 2:30? Which implies kind of an open-ended commitment to coming back for more and more sessions. And clients may read that as an interpretation on our part that there's something significantly wrong with them, that they're going to need to have repeated appointments. And there are other examples of that in how we discuss our fees, how we discuss billing. And many of these are pessimistic examples of how we communicate about change. Frequently, you'll hear a single session therapist be somewhere toward the beginning of the first session hear them say to a client, many people find, they're just citing the research here, Many people find that one session is enough to get them moving in the right direction, or to get them back on track, or to get them started on a bigger change in their life. And we'll check in at the end of the session with you and see where we are with that. So that's a little bit more optimistic than saying, this is just a session to get to know you. Most of the real change will be coming down the road. All right, let's move on to the next slide. This one is always controversial. It says that there's no correlation between the duration or severity of a complaint and the duration or the intensity of the treatment required. Now, this may seem to fly in the face of many of our taken for granted ideas about therapy, but there's really very little research that supports the idea that there's a direct relationship between the severity of a diagnosis or the persistence of a problem and the number of sessions required to help a client with a presenting problem. Now, I'm not confusing diagnosis with problem. And if we were to return to the Rolls-Royce analogy from a few minutes ago, in deciding whether we would need a Rolls-Royce or a Toyota, if you and I were having to make that decision about buying a car, do we want to buy a Rolls-Royce or a Toyota, it wouldn't necessarily be based on how long the trip was going to be or how complex the directions were to get from San Antonio, let's say, to Carmel, California. Either of those vehicles would be serviceable. We already addressed the idea that the history of the complaint and our client's history are important, but they're not important in the detail that we think. The next item is that we prefer to think of single session therapy as a consultation process in which the therapist offers ideas, many of which came directly from the client, and the client decides whether or not to accept them or to reject them or to put them on hold. This taking a stance as a consultant helps the therapist avoid taking too much responsibility for the client's change. We believe that their clients are their own best resource, and our job is to create a context that enables the client to discover those resources and to teach us how to be a useful guide for them. All right, let's turn to the next slide, and we'll just briefly talk about the three basic types of single session therapy. Basically, the first kind is the kind that we talked about in our thought experiment a little earlier. The client said, this is the only time I'm coming. They may decide at the end of that session unilaterally they're not coming back, or they may have had all in mind from the very beginning they were only going to attend one session. If I were to ask for a show of hands, if we were live again, if I were to ask for a show of hands at this point, if you've ever had a session with a client fully expecting that the client would return for a subsequent visit, and then they either canceled or no-showed for that second visit, there would be a lot of hands up in the air right now. And some percentage of those clients that didn't, the non-returning clients, I'm confident would tell you if you asked them that you'd been more helpful than you thought you had been in that session, and that's why they didn't come back. A second is an example of the second type of single session occurs when you meet with a client and you may decide at the end of the session that that session had been sufficient, or there's nothing more that further therapy would accomplish for them. Sometimes that happens by mutual decision. And that's when we make it explicit to clients ahead of time that one session of therapy is what we offer. We think of this as planned single session therapy, and there's several implementations of planned single sessions. Some clinics offer single sessions on a walk-in basis. Some clinics have appointments. There's all sorts of ways that could happen. So the literature describes a lot of different scenarios where clients and therapists meet one time. Sometimes, as I've said, it's because they got what they wanted. Others, therapists might decide that clients are good to go. All right. Let's move to the next slide, and this is the recipe. This is the agenda for a single session therapy. Now, the, it it might look like a checklist, and I don't want people to get that idea, because these are the different elements that go into make up a single session. Some of them happen earlier in the session than others, but we'll just break them down in this sort of a way. Any form of therapy has some structure and plan, and so does single session therapy. And in some ways, this is similar to some of the generic treatment plans that you find in psychotherapy. But the important difference is that a single session of therapy is accomplished in about an hour. It's possible for some to be as short as 15 to 30 minutes and for others to be longer. But generally an hour is what most of the research is about. It's the most common length. So if you have an hour of an hour to work with a client, you have to budget your time effectively. Sometimes I use the idea that it's like budgeting your paycheck. You have a known amount of income every month, and you have expenses that you have to meet every month. And so you have to think about how you're spending your money so that you can cover all of your expenses. So a single session agenda is like a time budget for therapists. I won't attach particular times to these various phases. I'll leave that up to you. The first phase is the joining and consent phase, and this is where you set the context for the therapy session. Here's any explanations or elaborations of consent can be provided. In single session therapy, I think of joining as in a couple of ways. First of all, I find this to be the beginning of the therapeutic alliance. And I use the word alliance, as I said earlier, because it implies that working together toward a common goal. The process of building and maintaining an alliance is ongoing, as all of us know, throughout a session. I also think of joining, though, as an assessment. I'm interested in their work. I'm interested in their family, their education, their hobbies, their interests, their even their politics, because those things can tell me about potential resources and strengths that the client already has that can be capitalized on. So most people, if you think about it, most people don't come to psychotherapy. We see in our offices a very small percentage of the general population out there. Many people have the skills, the abilities, the resources that get them through life. And most of the time, the clients that we see have been getting through life pretty well on their own. So they have these resources. We just need to help them assemble those resources in a way that could be helpful to them. The second part of the session involves establishing with the client the purpose of the visit. So I typically might ask, when you decided to come talk to me today, what were you hoping would be different when you left? Now, this is very different from asking a client what their problem is or what their concern is. And although some clients arrive at therapy wanting to become involved in long-term growth and self-discovery processes, for the most part, clients arrive with a particular issue that's been troubling them for some time. So early in the session, I say something like, so many people talking with us for one session is enough to get them moving in the right direction, back on track, ready to take the first step, and so forth. And I'll check in with you at the end and see what you're thinking about that. And in any case, you're always invited to come back for another session. Now, the third item in this agenda, and by the way, this is just an agenda for single session therapy. There are some that have a 3-act play metaphor for a single session therapy agenda. The third item in mind, though, I want to know what people have already been doing to work with the problem. Whose idea was it they come to see me? And maybe even some partial successes or inconsistent successes it has. Because this tells us something about what kinds of solutions the client prefers. Now, we try to understand their theory of change in a way that fits within their worldview about what works. Some clients think medicine is the answer. Other clients think conversation with someone like us is important. Other people think learning is kind of the way change takes place. Some people think they have to be punished in order to learn things, and so on. So we want to find out what that theory of change is that our client has, so we can try to work with their theory of change rather than our theory of change. Now, the fourth item on their goal setting, that's probably the most important aspect of single session therapy. In all forms of single session therapy, the goal for the session is something small as a first step. In other words, we look at the ending of a session as a beginning, not an end. From the very beginning of a session, I might ask, if you knew you were on the right path when you left here today, what would you be able to do differently tonight or tomorrow? Now, solution-focused therapy, as an example, has descriptions of well-formed goals that are really helpful. Some people find the SMART goals template really helpful, but those are the kinds of ways of thinking about goals for therapy that are helpful in single-session therapy. I'm really a strong believer in success breeds success, and if we can help arrive at the end of the session with a small plan for the client to put into play as soon after they leave as possible, that is likely to produce some success, that will breed even more success. Toward the end of the session, toward the end of the session, we do something I call commendations. And this is when we report back to the client what we discovered about their resources and strengths during the interview. Now, this is analogous in some ways to analogous to the ways of working where at the end of the session we tell the client what was wrong with them, a diagnosis in other words, or we would tell them what the results of their personality inventory were, or something like that. But in our way of working, this is where we report back what we understand their strengths and resources and capabilities to have been. Obviously, we had to conduct an interview in a way that we uncovered those. So if you're used to doing a diagnostic interview where you're looking for symptom history and symptom examples and so forth, then you'll overlook the strengths and resources. So we could be accused of overlooking those kinds of things in favor of looking for the strengths and resources. This part of the interview and sharing with clients what we have seen as useful and important for them in their lives is, for many clients, it's the most powerful part of the interview. It builds confidence in them. It builds motivation in them to be able to make the next step. And finally, the last part of the session, the very end of the session, we may have come up with some homework assignment or an experiment for the client to try. Recently, we've started asking clients toward the end of the session, perhaps even before the commendations have been delivered, what have you found helpful so far today about this session? And inevitably, believe it or not, inevitably clients will report what's been helpful. Now, this is very important. It's not, have you found this session to be helpful so far? Do you like what happened so far? We want to know what's been helpful. And they may say, having someone to talk out loud about these things with, or I've been carrying this burden for a long time. It was really helpful to get it out into the open, or it was really nice that you listened to me non-judgmentally. Whatever they might say had been helpful. By the way, they rarely say, that was really interesting the way you reframed my problems or the way you interpreted my dreams. Most of the times what clients have to report back as helpful is different. But when they answered that question, I follow up with a second question. I might say, so, Mary, if being able to talk to someone for the first time about these things that happened to you was the most helpful thing about this session, what is it going to enable you to do tonight or tomorrow? So I try to tie immediately in the session what's been helpful to some future action or future activity. So that what's been helpful actually frequently determines for us what the homework assignment is going to be. And the last is we always ask for feedback at the end. Did you get what you were hoping? You might say, remember at the beginning I said many people will find one session is enough to get them started. What do you think about that? Some people say, yeah, let me try some things out and maybe come back later. We might say, we rarely, if ever, say, so do you want to come back next week, or how about in 2 weeks? We let the client decide what the dosage is for them. Again, this is in cases where risk is not a big issue. We'll talk about risk later in the question period if we need to. At this stage, we also might suggest some other resources that might be helpful to the client. Could be, in some settings, we might refer them to a group or to a psychoeducational experience or some online therapeutic tools. That's the sort of referrals that we might make at the end of a session. Okay, let's move on to walk-in, and we'll go through this pretty quickly. But walk-in therapy is both similar to and different altogether from single-session therapy. Single-session therapy and walk-in single-session therapy both treat each session as a complete therapy in and of itself. But in both approaches, the clients present a concern, goals are constructed, and both aim for the clients to leave with a sense of hopefulness. That we want them to know that they've been heard and have gained an awareness of their strengths and resources. Now, in some circumstances, clients may have begun to develop a plan on how to address those issues at the end, but the difference between walk-in, but the difference is in walk-in therapy, people come in when they want to. They don't schedule an appointment. Some of you are quite familiar with that practice in clinics. It's sometimes called drop-in, sometimes called walk-in, sometimes called same-day appointment. But basically, people come when they're ready to. There's no appointment procedure. There's no pre-screening. Clients determine who is seen in a walk-in clinic by simply showing up. Now, we live in a fast-paced world. Schedules are tight. Meetings and appointments are squeezed into narrowing time frames. Family, work, leisure demands compete with one another. In this environment, there are times when it just isn't possible to plan and make an appointment. The business world is adapted by developing services that are immediately accessible without prearranged appointments. Hence, we have fast food drive-ins, drive-in banks, walk-in hairstylists, no appointment necessary, income tax services, instant breakfast, and even walk-in wedding chapels. So walk-in medical clinics, on a more serious side, walk-in medical clinics have been around since the 1980s. Patients can walk in and see a physician without an appointment. There are many of these things that I jokingly refer to as doc in the boxes around the country, these emergency medical clinics where people can come in and get treatment without a prior appointment. Signs that are advertised walk-ins welcome are commonplace, and walk-in services are becoming more common because they fit into our lifestyles. So what about walk-in mental health services? Well, why not? Walk-in mental health services are based on two really important ideas. First, it eases access to mental health services by eliminating the hurdle of waiting for appointments and other administrative procedures. There was an interesting study. Barlow was one of the authors, and I'm pretty sure I included it in the bibliography, that did a huge meta-analysis of what happens in traditional mental health clinics. And in many clinics, there are 3 contacts with a client before they actually get to see a therapist. There's a phone call, there's a screening interview, there's an assessment, and then they actually get to see the therapist. And the attrition rate is substantial. It's about 50% between each of those steps. So actually about 33% of the people that make a call to a mental health clinic actually end up seeing someone for services. Walk-in therapy enables clients to meet with the professional at their moment of choosing. There's no red tape, no triage, no intake, no wait list, no wait. There's no formal assessment, no diagnostic process. It's just 1 hour of therapy focused on the client's stated wants and needs. And as well as meeting client needs, walk-in therapy is highly rewarding to professionals due to the simple fact that clients' ability to access the services at their chosen moments of need without having to jump over multiple hurdles means that a large percentage of clients are highly motivated when they come in for a walk-in appointment. And pragmatically, with walk-in therapy, there's no missed appointments, there's no cancellations. It increases efficiency. So let's turn to the next slide and look at what a typical flow would be in some mental health walk-in clinics. And this is, again, just a general idea about what this could look like. But the client walks into the clinic. We're not doing much walk-in due to the virus right now, but many areas that offered walk-in services before now have adapted to doing walk-in or call-in therapy where services are available at the time that the client wants to call in. We've adopted that in our clinic. I know many university counseling centers around the country have done that. Perhaps some of you have switched to virtual. So the walk-in works just as well. In fact, in Canada, there's a project called Wellness Together Canada, where any Canadian citizen, there are phone numbers that people can call whenever they want to talk to a therapist for an hour, 24 hours, 7 days a week. So that's the ultimate in walk-in services. But when we get back to normal, the client walks into the clinic. They are greeted at a reception desk. There's a brief check, perhaps, to be sure that they're in the right place. All of us know that sometimes clients wander into the wrong office. Somebody, could be an admin person, could be the receptionist, gives them consent forms to fill out, a brief demographic form, and maybe a short questionnaire. In our clinic, the paperwork combines demographic data with some questions about what the client's concerned about, what the resources are they have, what strengths they think they have. and a Likert scale that asks how worried they are about harming themselves or someone else, and a few short answer questions like what would be a small sign that lets you know that we're headed in the right direction at the end of the session. Our paperwork is one 8.5 by 11 sheet of paper, two sides. It takes clients anywhere from 5 to 10 minutes to complete that, maybe another 5 or 10 minutes to do the consent form. And then the paperwork is brought to the therapist. In our clinic, we're in a training setting, and so the paperwork is reviewed by a supervisor and a number of therapists that might be working with the client. In other settings, many of these steps are skipped, and the therapist on duty for walk-ins gets the referral information, the intake data, and goes to work. So the clinician can meet with a client for 45 to 50 minutes in a single session format that we've talked about a little bit earlier. And at the end of sometimes in some settings, especially in some group training sessions, there's a break in the session where the therapist will actually consult with the rest of the team about the case. Some people working by themselves have found it really very useful to just take a short 2 to 5 minute break from the client. Tell the client, I'm going to take a little break here. We've talked about some really important things today. I want to have a moment or two to think about what I've heard and what I'd like to leave you with before we end for today. That's a little bit unusual in some practices, and it's not required, but it's often useful. And then after that, that's when we go into the closing that I talked about a little bit earlier. The commendations are provided, the homework plans, and the client leaves. And of course, if risk issues have arisen either before or during the session, safety planning would have taken place during the session, and plans for some kind of follow-up might be made. But typically in walk-in counseling, walk-in clinics, follow-up is not a routine part of the process. And then you have 10 minutes to write your notes, and the notes get written up and put in a file. So, single session therapy is quite well suited for walk-in clinics work. By the way, there was a well-known health economist, Ezekiel Emanuel, the brother of Rahm Emanuel, who was in Obama's administration. Emanuel Ezekiel has recommended that physicians devote 40% of their schedule during the day to what they call open access, which is basically walk-in. So medicine is moving in a direction of becoming more accessible for their patients. So let's move on to the next slide. It looks like we're right on schedule to be ready for questions in just a minute. So the next slide, this is what we want clients to leave with in any, whether it's a walk-in session or a single session therapy session. We want clients to have a sense they've been heard. We want them to have a sense that somebody took the time to listen to them in a judgmental way, a non-judgmental way. A study that was done by my colleague Arnie Slive in their walk-in clinic in Calgary a number of years ago, when they followed up with clients to the walk-in service, asked clients what the most helpful part of the visit had been for them. Almost all of them said, somebody listened to me. I had somebody to talk to. We often underestimate how important that is to clients. The second thing is that clients often arrive at our door having lost hope. They're stressed, they're feeling hopeless. one of my colleagues pointed out that we see most of our clients, if not on the worst day of their lives, maybe during the worst week of their lives. They're feeling helpless and hopeless. By the end of a single session of therapy, we want them to have an increased sense of hope. We want their stress level to go down. We want them to have reclaimed some of their autonomy. Third, we want them to have an increased awareness of their strengths and resources. We underscore and reflect for them on these strengths and resources during the session that we've had as they arise, and we reiterate them with the commendations phase of the interview. And so we hope that in doing so, along with establishing what the session may have empowered them to do, it will point them toward using their resources more effectively. Fourth, John Weakland, some of you know John from the Mental Research Institute. He's been known to have said life is just one damn thing after another. But problems are the same damn thing over and over and over again. Well, we hope as single session therapists to help clients think about their original problem in a new way, to change their relationship with the problem. Perhaps to move from all or none thinking to more variability in their thinking about a problem. Fifth item, essential to the single session therapy approach, is that the client leaves with a plan for their next step about the problem. We have faith that getting the ball rolling in the first step is enough to keep it moving. We always invite clients to come back. And sometimes we might say, try this. If it works, great. If it doesn't, come back and we'll fine tune it a little bit. And lastly, we want clients to have had a positive experience with psychotherapy. As we saw earlier, most clients only give therapy one chance, one shot. Single session therapists want to make that experience, want that experience to have been positive. We want them to come back in the future if they found the session helpful. We want them to tell their friends and their family that they had a successful visit. For some, single session therapy is an opportunity to try out therapy. It's kind of like some gyms offer a one-time visit. You can come in and try it out. In our clinic, we often find clients that they're on the fence about whether or not they think psychotherapy is something that could be helpful to them. They come for one visit to kind of test us out. We want to be sure that we provide them something that was useful in that one visit, that's not an assessment, that's not we'll tell you a little bit about how long the road will be for you to if you're in therapy. We want to be sure they get something out of that session so that if they want to come back, they'll be interested in coming back. We want clients to have a time to see that they can, if we can help with the small, to get the idea that if we can help you with small things, maybe bigger things are on the horizon that we can help you with as well. All right, that's the, so the next slide should be the questions slide. So I think we've timed that pretty well to leave time for some questions. Let me look down in the chat. Does insurance pay for single session therapy? That's up to the insurance company. Many insurance companies require you to provide them with a CPT code and a diagnosis, and that's what's important. So you can, yes, they do. And in our clinic, we do a lot of cash payments, so that's another way that it's done. Is it still billed as 97? Somebody who's an expert on billing could respond to that. Are specific consents required? No. Darla, if you have a specific item in mind about what might be in there, if you just put that in the chat for us. OAAT is one at a time. I'm sorry I didn't make that clear a little earlier. Are there available videos? Wendy Dryden is a single session cognitive behavior therapist. He's based in London. And if you go to YouTube and put Wendy's name in, it's DRYDEN, and single session therapy. He has a lot of videos up, and some of them are little snippets of single session therapy. If you send me your email and let me know that you're interested, there's a demonstration interview that one of my colleagues in Canada did. That's available. It used to be on YouTube, and if it's not still on YouTube, I have a link to another source for that. I regularly show examples of single session therapy in my one-day workshops. Let me see, does the time for single session have to be Maria Isabel, that's a really good question. It can be however long it takes. We have done sessions in our clinic as short as 15 minutes. Sometimes it's been longer, but for the most part, it fits comfortably into a practice that works around a 1-hour session. But I don't think therapy has to last a whole hour. If you can get done sooner, you could get done sooner. Oh, you didn't get a handout with the bibliography. Susan, is there a way I can send that? I thought Justin had it and send it out. I can certainly provide it to APA and they can distribute it. We'll figure that out. Maybe one of the support people can tell us how to make that happen later. Do you have suggestions about how to help a client who has had therapy all my life change their mindset from long-term to single session therapy? That's a really good question. It comes up a lot in university counseling centers where students arrive at college and their parents have had them in therapy for a long time. Part of it is helpful if the therapist has a single session mindset. So Stacy, it's a complicated question. I might ask the client, what's been helpful about therapy so far that you've been having it all your life? It could be that they've had really good therapy, but therapy isn't what they need. Therapy is not the answer to everything. So what I would do, one suggestion is to say, well, I know you've had therapy all your life, but what are you hoping to get out of today's session? If you and I are successful working together today, so that you feel like we're going to be going in the right direction, what will you be able to do today when you leave? And then when they come back the next time, I will ask them, what's gotten better since you were here before? In fact, that's the way I always start sessions. What's gotten better since you were here before? What's gotten better since you made the appointment to come in? I'm always looking for improvement so that we can push people in that general direction. So that's kind of a quick and dirty answer, Stacey. That's about the best I can do right now. Philip, I see lots of folks who can't articulate a goal beyond feeling better, even when asked questions, if you were better, what might you do differently? Yeah, that's not unusual, and so these are not magic questions, but they're just different phrasings that I use frequently. Is if you were feeling better, what would your friends and family see you doing? What would your wife see you doing that would let her know or him know that you were feeling better? So if you were better, what might you do differently? sometimes is a little bit vague. So I ask, what would other people see them doing, or what would they hear them say? What would your boss, if your boss were to hear you say or do something at work tomorrow that made him think, he's, I think Joe's feeling a little bit better. What would he hear or see? That I would really work hard to break that down to something small and behavioral. Patricia, how do you work with suicidal clients? Are they exceptions? No, they're actually not exceptions, because the single session model is very appropriate. If a person comes in and they're worried about suicide, you want to be sure when they leave that you and the client are not worried about suicide anymore. Now, you might be, single session therapy could be developing a treatment plan or a safety plan. Or in some cases, that's one of those 20% that really requires something other than single session therapy. I have a number of cases that I got a couple that I frequently show as examples when I do workshops of people that have come in. One recently who was referred to us by the suicide hotline that he had called earlier in the day. And during the course of the therapy, this therapist said, well, when you were sitting in your car talking to the suicide hotline today, where on a scale from 1 to 10, how worried were you that you were going to kill yourself? He said, I was about a 7. She was asking this question about 40 minutes into the interview. And she said, so whereabouts are you now on that scale? He said, oh, I'm about a 7. I'm not worried about hurting myself now. So just in the course of the interview, the worry about lethality had changed significantly. That didn't mean that we wouldn't want to follow up. That would be the exception to the general rule that we don't follow up. So I hope that's helpful. And yes, see, when you ask, can you make exceptions? You can make exceptions. You could see them again if you need to. Yeah. Okay, let's move on to Astrid. Do your consent forms include teletherapy? Yes, we have modified the consent forms that we use in our clinic, I'm sure, just like everyone else has done, to provide teletherapy. We protect clients from potential harm the way anybody else would do. In other words, my generic answer is we handle risk in a very professional way, the way any other professional therapist would handle it when issues of risk come up. So we don't blow people off or say we don't do that in single session therapy. And Astrid said, is there a shortcut for record keeping? We have to keep files for a long time. Those are, you'll have to ask somebody else about that. I'm not I don't know if you mean, is there a shortcut, like can you throw them away after 2 years? Or is there a shortcut for the notes that you're taking? Those are the video that my Canadian colleague does. She uses a form in her interview that guides her interview, and she's taking notes during the interview on that form. And when the session is over, she gives a copy of the note to the client, and a copy of the note goes in a file. And that's the extent of the note-taking, record-keeping that they do. But that might not work in your setting. Yeah, what about people who come in over and over again because they want to vent, and about clients who are currently in therapy elsewhere or who see the walk-in session? Wow, it sounds like you have read, that was the subject of one of the book chapters that Arnie and I wrote about that's one of our frequently asked questions. So let me see if I can find an easy way to respond to that. if clients are in therapy somewhere else, and then we ask them what is it that they're hoping to get out of this session that they will be able to take back to their session with their other therapist. We have to dance. We usually don't want to see people more than once under that circumstance, because it just is a bit of an ethical, legal issue about working with somebody else's clients. Some clients that see a walk-in session as session number one. Some clinics set things up like that so that you can walk in. That's how you get into long-term therapy. So if you're working in a clinic where walking in is the front door to a longer term of therapy, that's just the way your clinic is set up. That doesn't mean that you can't treat every client that walks in expecting that they're coming in for long-term therapy as if it would be a single session, because you get to the end of that session and say, so did you get what you want? And they said, oh yeah. We have clients not infrequently say, yeah, when I was thinking about coming here, it took me a long time to come because I was afraid I'd have to be coming for therapy for years. But you've helped me enough today that I think I can take some of these ideas and try them out, and I'll let you know how it's going. So it's the idea is every session has the potential to be a single session. Richard is working in Richard is working in a Bureau of Prisons. I have an intern, a doctoral student that worked quite a while with me doing single session therapy in our clinic, who's going to a federal prison in Colorado to do an internship. There's a couple of articles in the bibliography about using single session therapy with substance abuse. If you're in a setting where you have access to EBSCO or any of the major search engines, if you put single session therapy and substance abuse in your search terms, there'll be 2 or 3 or more articles pop up on that. Karen. Karen, the idea about people that have had a history of long-term therapy and they're expecting the same is that they're expecting that's what you're going to deliver, or that's what they want. And so what I might say is, that's great. What do you want to work on, and how can we use today's session to get you prepared for your next session with your long-term therapist? How can we use today's session to help you organize what the goals are that you want to work on in your long-term therapy and so forth? So again, we want to help them with whatever they come in with, and some people want to come in and do long-term therapy. And so I introduced the idea that, well, you've had what was helpful about those long-term experiences, and what is it that, if you continued in therapy, would you like to get that you haven't gotten already? And maybe that could be something that could be handled in a single session. Susan, Justin, Justin's saying we have to wrap up. Is there a way that people could have my email address so they could ask me, like Ryan's wanting me to email him some information about videos? Can we post my email in the chat? I'm not hearing anything from Justin or Susan, but except that they said we need to wrap up.
This is Susan. Can you hear me?
The email that you have, Justin, is fine. If the one that's at olusa.edu would be fine. So Justin's telling me that our time is up and that we need to wrap up. So I just want to say that I really appreciate the opportunity to present this work to you folks today. I'm hoping it was helpful to you. Please email me if you have further questions or you want more resources. Justin and I will figure out how to deliver that bibliography to you. So thanks again. Bye.
That's all the time we have for today's webinar. On behalf of the APA, we would like to thank our presenter for today's presentation. Of course, we would also like to thank you for tuning into today's program. Remember to receive continuing education credit, you must fill out the evaluation. You will receive your documentation soon. This concludes today's presentation.